Okay, hello, friends. It is our second episode of T4, Tots to Teens Tidbits, and I am very excited to introduce our very first guest lecturer for T4, Dr. Joseph Lamb. He is an amazing guy, a colleague in PD Derm. I've known him through the Society of Peds Derm for many, many years. He is an overachiever of sorts. He's trained at UC San Diego at the Rady Children's Hospital and also University of Toronto at Sick Kids Hospital, so had some great experience. And now Dr. Lamb is a clinical associate professor at BC Children's Hospital. He practices in British Columbia, Canada, in Vancouver. So he is coming to us very early in his afternoon and made time for us today to be our guest lecturer. And again, he is a great pediatric dermatologist. He loves to teach. He does a case of the week with his residents where he trains students to help kids love the skin they're in. And I am just so excited to hear what Dr. Lamb has to share with us today about the history of pediatric atopic dermatitis.
Thanks so much, Alana. It's such a privilege to be the first guest speaker. It's so exciting. And I'll be talking about another thing of sorts, not as much first, but things, the history of eczema. Because eczema, it goes, if you trace history, it goes back centuries. And it's really cool to think about this. So for today's Tots to Teens Tidbits, we'll talk about atopic dermatitis. I have disclosures, relationship with commercial interest, but the content today is all mine. What we'll do today is we're going to trace the descriptions and treatment of atopic dermatitis through the centuries and look at the current treatment of atopic dermatitis and look at some differences in terms of what we see clinically, but also in the immune system in patients with darker skin. So let's dive in. So atopic dermatitis in history. And as we look onto history, it's kind of neat. We can reflect on the advances we made over time, but also mistakes that we've made as lessons for today as well. So this is Carl Sagan. He's an astrophysicist. He's not a dermatologist or a pediatric dermatologist, but he has this great quote, which says, "You have to know the past to understand the present." And that's very applicable to atopic dermatitis. Some of you might see this all the time in clinic, an itchy kid with red, scaly skin. Well, it's not just a current thing. It's been happening for centuries and centuries. And one way to look at ancient history is to look at things that have been passed down through generation to generation. One way to look at this is look at ancient China. There's a lot of practices that are done today in traditional Chinese medicine that have been passed on from generation to generation. And so hints from the present about the past. Well, what we do in the present is that a lot of people practice traditional Chinese medicine, but that gives us hints as to this disease. And there's a lot of herbal remedies for atopic dermatitis. There's even a Chinese term for infantile eczema. In Mandarin, it's shizhen. In Cantonese, it's sapzhen, which means wet rash. And there they thought it was an imbalance between yin and yang of the body. However, that's oral tradition. Once you have things written down, you can really document it well. And that's what happened in ancient Egypt around 1550 BC. You have the Ebers papyrus. So in Egypt, they developed a way to make paper out of papyrus. And there you can document things and we can look at it many years later. So if we look back, we find this document that's there about Egyptian medical practices. It's the oldest papyri we can find, and it has all these different magical formulas and folk remedies. And in it, it contains remedies to still itching of the skin. Now we know that it's not just eczema that is itchy, but gives us hints as to how long eczema has been going on, because certainly some of these patients they're treating probably had eczema. Let's fast forward a little bit to ancient Greece and Rome. And this is Hippocrates, this picture of this guy on the left. This is around 400 BC. He was considered the father of modern medicine. Why? Well, before Hippocrates, people thought that diseases were caused by superstition or by displeasing the gods. Hippocrates said, no, it's not. It's caused by natural causes. And that's kind of revolutionized how people saw medicine. And he explained the skin conditions as a skin or cutaneous manifestations of internal humoral imbalances. What we mean by that is he thought there's different humors in the body: blood, black bile, green bile, phlegm, and that the body's trying to balance this out. And in the skin, we see this balancing mechanism of the skin getting rid of the bad imbalances that are there. Certainly different than our thinking about the skin today. There are also more accurate descriptions of eczema from early Greek and Roman times. This is Cornelius Celsus. He was a Roman encyclopedist, and he had this famous medical work called De Medicina. But in that, he described a condition with a certain degree of hardness of the skin, with pustules, some humid or wet, and some dry. And that's very similar to patients with eczema. Some pustules here, some wet exudative lesions here, and some dry spots. What gave us a really good, accurate description of eczema, however, was the description of the very first Roman emperor, Augustus. And this is by the historian Suetonius, who said, Augustus's body was marked by a number of hard, dry patches that looked like ringworm, but very, very itchy on the skin, and caused by too vigorous use of scrapers at the bath. But he also said he had a tightness of the diaphragm in early spring. And this very funny phrase, when the sirocco blew catarrh, and it sounds like a different language, but the sirocco is just this Mediterranean wind that would blow in. And the catarrh just means rhinorrhea or runny nose. Basically, this historian was describing about 2,000 years ago atopic dermatitis, asthma, and allergic rhinitis. So this is a paper from 2,000 years later by Amy Powler talking about this atopic triad, the atopic march, atopic dermatitis, asthma, and allergic rhinitis. That was described 2,000 years ago in early Roman times. Let's fast forward a bit to post-classical history. In the European world, this is considered the Dark Ages, but other parts of the world, there was flourishing. And one area where there was a lot of flourishing was in medieval Persia. And here it was considered the Islamic Golden Age, where there's a cultural, economic, scientific flourishing with innovations in foods like coffee, cultivation, university algebra, surgical procedure. One of the polymaths, or the Persian intellectuals, also wrote down several conditions and treatments consistent with atopic dermatitis and dry skin. And interestingly, back then in about 1000 AD, noted a connection between bathing, too much bathing, and then dry skin, which is interesting because this is the Eczema Society of Canada's handout on atopic dermatitis, also emphasizing the same thing about not bathing too much. Let's move on from the Islamic Golden Age to the European Renaissance. And that brought us many beautiful things like art and sculpture. One amazing thing that came out through the Renaissance was the printing press. No longer did people have to just copy things one by one. You could mass produce literature. And not surprisingly, following this, we had all the medical textbooks, the preeminent textbooks on dermatology from Italy, from France, and from the UK. And all of these fathers of dermatology describe this itchy skin condition in infants, which we know today to be atopic dermatitis. But we still did get some things quite wrong. Remember that Hippocratic theory of the humors in the body? People still believe that as an explanation of why you have this oozing skin in atopic dermatitis. They thought you have this disequilibrium of humors inside the body. And what you see in the skin is the skin's attempt to try to balance out these evil humors that are there. So people actually feared treating atopic dermatitis, thinking that by treating the skin, you'd worsen an internal condition. And you can see this in, played out in different ways. There's a body of thought. I think this is Latin, noli me tangere, don't touch me, leave me alone, don't treat the skin, because they thought that things would get worse. And they also favored non-topical treatment of eczema, either not treating or even treating orally, and they feared topical treatments of eczema. This is from Daniel Turner, the father of English dermatology, and he writes in his book, Itching Humor, Eczema, if you try to heal it, you might quickly cure them of their itch, but you will as certainly put them into hazard of their lives because you'll pollute their blood and nervous fluid by driving back the excrements into the vessels. Basically saying, hey, don't fix the skin. The skin is trying to get bad stuff out. Let it happen. If you fix the skin, it all gets stuck inside. This is Ernest Gaucher in the first International Congress of Dermatology from 1889. He said, the skin disease is like a safety or like a safety valve. If you make it disappear, then the elimination of toxins is suppressed and can produce internal disturbances. So with this frame of mind, you can imagine that people didn't treat eczema very effectively. They tried to cure the disease internally with things that were frankly dangerous, giving sulfur, arsenic, or mercury. They tried to increase oozing of the skin because if you think that the oozing is helping, then you might put things on that will make it ooze more. And they did that. They put mercury in the skin, or they wrapped the body in rubber to have them sweat it out. Or sometimes they actually open up the skin with bloodletting, leeches, or try to eliminate substances through diuretics or laxatives, thinking that it's toxic. And interestingly, you can see some parallels with today, sweating out toxins in hot yoga, or don't try coffee enemas. Other setbacks to effective therapy, similar to today, where people tried diet modification as a treatment for eczema. It'd be great if it worked, but it did not work. And sometimes it was quite damaging to the infants. They would try to replace cow's milk with wheat flour with different formulas or diets called Moll's pudding or Epstein's diets and other diet manipulation that did not work. Fortunately, there were some advances in the 19th century. Just giving it the name eczema really made a difference. The word eczema comes from the Greek word exine, which means to erupt or boil over. And when you see a child with acute eczema, it almost looks like the skin is boiling over. That was really, really important because giving it a name, you can classify things and see things in one group. Before 1818, there's all these different names for conditions that were eczema, but people didn't see it as one disease. Before 1818, you have names like Strophiolus confertus, Lichen agrius, Porigo larvalis. It sounds like a Harry Potter spellbook. But after 1818, you start seeing the term eczema coming to the lexicon, and you can group all these things together as, oh, this is all a form of eczema. Other advances in the 19th century. Not everyone believed Hippocrates, thinking that it's the humors in the body. Some people believe that the skin is responsible for its role in disease. And two people, von Abra and his son-in-law Moritz Kaposi, were very instrumental in saying, no, the skin is where the problem is. And they used topical remedies like tar and sulfur to help treat the skin. And they also suggested not too warm bathing, and also emollients to help the skin out. Other advances in the 19th century, people started recognizing the importance of itch in atopic dermatitis. Here's the English dermatologist and surgeon Erasmus Wilson describing the severe itching that happened in the patients that was much worse at nighttime. And here's Ernest Besnay also focusing on pruritus, as much as what we see in the skin, how patients feel under the skin, and also link this to atopic processes like asthma and hay fever. Other progress as we move into the 20th century. Here's the Austrian pediatrician von Perquet, who first introduced the term allergy. And in 1923, Koka and Cook proposed the term atopy, meaning no place, or atopic, meaning strangeness or out of place. This disease is different than other diseases, atopic dermatitis, allergies, asthma, hay fever. It seems to be something that's separate. And in 1933, Fred Wise and Marion Schulzberger introduced the term atopic dermatitis with a description of this as being a diffuse and pruritic skin disorder characterized by family history of atopy, flexural distribution, previous history of infantile eczema, certain blood serum components, IgE, and other features, which is very similar to how we see atopic dermatitis today. Marion Sulzberger, this guy right here, he's also very instrumental in this paper in 1952, where he talked about the effect of topically applied compound F in selected dermatoses. What is compound F? Well, compound F is hydrocortisone. This is the first reported case of using hydrocortisone topically to treat atopic dermatitis. So a lot of people historically talk about BC before Christ, or BCE before the Common Era, or AD or CE. But some dermatologists consider BC as before corticosteroids, before 1952. Life was very, very different. And after 1952, wow, things have really changed. If you look at the treatments that we have for atopic dermatitis, Topical corticosteroids were first discovered or used for atopic dermatitis in 1952, and still to this day, they're a very important part of our treatment armamentarium. It wasn't until about 50 years later that we had the next class of medications, the calcineurin inhibitors, tacrolimus and pimecrolimus in 2000 and 2001. It wasn't another 50 years before we got another class of medication. It was about 20 years later that we had the new kid on the block at that point, which was crisaborole, a phosphodiesterase 4 inhibitor. And then since that time, and I'll say in the US, because this is not available in Canada yet, we have topical JAK inhibitors, ruxolitinib, used for atopic dermatitis. Well, it's interesting. If you look at what happens in atopic dermatitis, intentionally, this is a busy slide just to show all the things that are happening in atopic dermatitis. But if you look at all the mediators that are here, there's things that we can actually start blocking even today. If you look at interleukin 4 and interleukin 13, the signals that are there for atopic dermatitis, we actually have a molecule that can block that. That's dupilumab or Dupixent, where it's an injectable. And now it's approved in the United States and Canada down to 6 months of age. Since I'm in Canada, here's the Canada data, but here's from a US website. It's approved for atopic dermatitis down to 6 months of age and for a lot of the other atopic diseases as well. Well, interleukin 4 and 13, there's a blocker for just 13 itself, and that's tralokinumab. In Canada, it's called Adtralza, but you won't recognize that name because in the United States, it's called Adbry, but the same molecule, tralokinumab, 4 and 13. If you look at other signals that are here, there's the JAK inhibitors. I briefly touched on a topical JAK inhibitor, but there are oral JAK inhibitors as well. And here we have both Canada and United States, Rinvoq, which is upadacitinib, and then Cibinqo, which is abrocitinib, orally to treat patients 12 years and older with moderate to severe atopic dermatitis. So maybe Hippocrates was onto something, not the evil humors in the body, but the humoral immune system that's involved, some things that we can target. So other thing to go back to this busy slide and to highlight is everything that is green in this slide is either a target that we have something available right now on the market to treat, or some things that are actually coming down the pipeline. So it's a very exciting time for patients with atopic dermatitis. It is a great time to be alive. And, that's looking at the past to see how we've understand so much differently now about how eczema works and how to treat it. But just know it's not just the treatment that we've learned over time. It's also the way that we see eczema. And one thing to really highlight is skin disease. It looks different in patients with darker skin. So pointing one thing out is that erythema or red is less noticeable. If you imagine that you had a white piece of paper and you drew on it with a red marker, the red is very, very obvious. If you have a black sheet of paper and draw on it with a red marker, it is not as obvious. Erythema or redness is much more obvious in patients with darker skin, in lighter skin. But in patients with darker skin, sometimes you don't see it or it looks more purplish or gray. And this is not just for eczema, but a whole bunch of inflammatory conditions. This is the now famous COVID toes that can happen with COVID. But you can see how much the red pops off the skin when in patients with lighter skin, but not as obvious in darker skin. Same thing with cellulitis and same thing with pityriasis rosea. But the flip side is also true, where things that are white or dark, or definitely if it's white, if you have dyspigmentation, it's much more noticeable in patients with darker skin. If you use the same white paper analogy, if you put white out on white paper, you don't really see it. But if you do that on darker skin, you can see it a lot. And that's why sometimes you can see more dyspigmentation on patients with darker skin. Why is this important? Well, sometimes you can miss the diagnosis of atopic dermatitis if you don't recognize the redness that's there, or even if you recognize it is atopic dermatitis, you might underestimate the severity of the atopic dermatitis. Here's a kid, if you feel the skin is rough all over, but you might only notice the red here, or if you look closely with this patient in person, you notice the child is red all over. Whereas this child, you can see the thicker areas here, but you can see that most of the skin is red. It's very easy to underestimate or even not even recognize eczema in a patient with darker skin. As I mentioned, the dyspigmentation is also much more noticeable in patients with darker skin. Here's a patient with atopic dermatitis. When you treat the atopic dermatitis, you have the post-inflammatory changes, the leftovers on the skin, but that can be really, really obvious. Fortunately for this patient, they knew it was leftover from the eczema, but some patients can come in with this and think either that it's still eczema, and they still treat this, or they can think it's a side effect of the medication when it's neither of those things. It's just leftover from the eczema that will get better with time. Just know that dyspigmentation can be much more obvious in patients with darker skin. That's with eczema, but also you can see it with patients with just dry skin. Again, it's like a whiteout or a white crayon that you're drawing, or chalk that you're drawing on. If you're drawing on a white piece of paper, you don't really see very much, but chalk on a dark sheet of paper, it shows up much more. Other interesting thing is distribution and morphology of eczema can also be different and can be you can be easily fooled sometimes if you're not used to looking at patients with darker skin. Here's an article from almost a decade ago talking about how atopic dermatitis can look different in patients with darker skin, with the example of African Americans. The morphology, you can see that these patients don't have scaly skin that you would expect in the typical picture of atopic dermatitis. Instead, they have papules that are here that are very follicular based, or sometimes they're scratched with excoriated nodules. You can see that much more commonly in patients with darker skin. We can also see is that the distribution, while it also affects the flexural areas, it can also affect the extensor areas as well. There's a nice quote that says, "Change how you see and see how you change." It's good to recognize this is how it can present in patients with atopic dermatitis with darker skin, and know this could be eczema, even though it looks a little bit different. Why does this happen? Well, actually, underneath the hood, we realize that there are differences in the immune signaling that happens in patients with different color skin. And this is not just patients with darker skin, African American versus Asian skin, which have pigmentation on their skin. Their TH profile can be very, very different, where there's almost absent TH17 in African American skin and a lot of signaling of TH17 in Asian skin. So we just know that there are differences that are there on the skin, but also in the immune profile that's there. What does it mean practically for our patients? Well, number one, don't underestimate eczema severity in patients with darker skin. Just know that there's the redness that's there, but you might not be able to see it as easily. And know that unusual morphology and distribution can happen in patients with darker skin, and it could be eczema even if it doesn't look exactly what you think it should be. And there are immune differences as well. But today, it doesn't really change our approach to therapy. The treatment is still the same, but who knows, maybe in the future, we'll have more precision-based medicine because of our knowledge. So take-home points today. History is not the past, but it's a map of the past. Useful for the modern traveler. Looking back at history and the history of eczema, not only is it very interesting to see what's happened in the past and the descriptions of eczema, but we can see the ways we got things right and also see the ways we got things wrong. But in this, we can see how progress works. We're not at the top of the pyramid right now. We're kind of on the journey, and some things that we do today that seem, standard and make a lot of sense. In the future, people might look at what we do today and think, oh, we were totally wrong. But there are exciting areas of medical advances for the future. And not just treatments that are there now, but in the future, there are a lot of things coming down the pipeline that can really, really help our patients with atopic dermatitis. And just know that it's not just treatment, but we're also advancing in our knowledge of recognizing how atopic dermatitis works, especially in patients with darker skin. And with that, I'll stop here and open it up for any questions that people may have.
Oh my goodness, Dr. Lamb, that was amazing. Thank you so much. You took us on a great journey. I loved it. The atopic dermatitis journey through history, really. You are a gentleman and a scholar.
I think it's fascinating to learn, and it's really good to see what's happened over the years. I mean, smart people were thinking about things, and even like back in Roman times, like just describing what's there, but trying to fit it into a world frame that made sense. We sometimes got things wrong, but I think the important thing is just to recognize what's happened before and then use that knowledge to build on it, but also not to hold too tightly to the things that we think are absolutely true.
I think that's amazing. Amazing advice. And yes, so much information. I learned so much, and I know our learners are going to learn so much. I don't see any questions in the chat right now, but in the chat, They have shared how you guys can sign up. So if anybody's watching this lecture right now recorded, please know that you can join our community at any time to watch live lectures. But then also, these will be recorded and can be shared. So again, please sign up to be part of the T4 community. It's only going to continue to grow, and we're excited about that. And again, if you have any questions, you guys can always email pdderm@sagisdx.com. And if I can't answer those questions, I can pass it along to Dr. Lamb. He does have a different perspective. And that's what I love about this series too, is we're all learning from each other, because medical education is a lifelong journey, and that's what makes it so special and so wonderful. And again, thank you to my colleague, Dr. Lamb. Amazing, amazing, amazing talk. Thank you for being our very first guest lecturer. And I am already excited to have you back when you're available to talk about anything at all that you want in the future. So thank you again. I appreciate it.
It's a pleasure. Thank you so much for the opportunity. It's a great thing that you're doing. Medical education. It's great because you can get the knowledge out to so many people, and then you can help so many more people by doing that. So kudos to you guys for doing this.
Thank you. That ripple effect, and thanks for being part of it. All right, friends, it is a good afternoon to our friends in British Columbia, Canada, and a good evening to our friends here in Central Illinois, Wisconsin, wherever I am, I don't know. But that's the great thing about this online learning. You can be anywhere and take it in. So anyway, good night, and thank you again.